Welcome back. We are on chapter 20. We are halfway through. We are at cardiac emergencies. Topics we're going to discuss are going to be cardiac anatomy and physiology, acute coronary syndrome, and cardiovascular disorders. In this first section, we're going to talk about cardiac anatomy and physiology. So cardiac anatomy and physiology. So the review of the cardiovascular system is the composition of the blood, the flow of the blood through the chambers of the heart, the flow of the blood through the arteries, the veins, the arterioles, the venules, and the capillaries, as well as circulation of the blood between the heart and the lungs and between the heart and the rest of the body. The only job of the heart is to actually pump the blood. So it's the generation and distribution of the electrical charge. The mechanical response to create rhythmic and unceasing pumping action and requires constant supply of oxygen and nutrients. In this diagram is going to be all of the coronary arteries. All right, let's think about it. So how does the normal function of the heart and the blood vessels relate to the blood pressure and the distal pulses? And then how is shock related to the function of the heart and the blood vessels? So remember that the heart is the pump and the blood vessels are the container for the blood and the cardiovascular system as a whole. So the size of the container and the force of the pump create that pressure within the system to circulate that blood. So this pressure is measurable when we use a blood pressure cuff and then assess the blood pressure, and it is also palpable by feeling for the distal pulses. And then shock occurs when the pressure within the system falls and the blood fails to actually circulate properly. In this section, we're going to talk about acute coronary syndrome. All right, acute coronary syndrome is sometimes called cardiac compromise. It refers to any time that the blood supply to the cells of the heart is blocked or disrupted. And then the heart muscles go without oxygen, causing cell death. So you want to remember that the acute coronary syndrome, or also known as ACS, is a blanket term that refers to any time that the heart may not be getting enough oxygen. All right, a hypoxic condition of the heart is called ischemia. And then the cells die quickly without adequate blood supply. So as an EMT, you should treat all patients with ACS like the signs and symptoms as though they are having an actual heart problem. With acute coronary syndrome, chest discomfort is best known symptom. It can be described as pressure, squeezing, or aching. It can radiate to the jaw, the neck, or either arm, or even the upper abdomen, especially in women. And then dyspnea is just another common finding in those older patients and women. Of course, there can be multiple other symptoms, including nausea and vomiting, syncope, sudden onset of sweating, abnormal pulse, which is either tachycardic or bradycardia, abnormal blood pressure, anxiety, and then feeling of impending doom. So remember that chest discomfort, dyspnea, nausea, and anxiety are common symptoms of ACS, but not all ACS patients present with common symptoms. So for your patient assessment with the acute coronary syndrome, you want to perform your primary assessment, explore their chief complaint, use OPQRST and get a history of their present illness, and then obtain the past medical history and take your baseline set of vitals. During your patient assessment, you could have some of the following signs and symptoms of ACS: pain, pressure, or discomfort in the chest, the jaw, the neck, the arms, or the upper abdomen. They might have difficulty breathing, or they might have palpitations or sudden onset of sweating and nausea or vomiting. They might have a syncopal episode, anxiety, unusual generalized weakness, abnormal pulses, and abnormal blood pressure. During your physical exam, they could be grabbing or clutching the center of their chest, sweating, pale or gray skin, anxious or restlessness. That's why it's always very important to know different signs and symptoms to be watching for. You might find them to have acute pulmonary edema or swollen ankles and feet, or have a medical alert jewelry indicating that they have cardiac problems. With the 12-lead ECG, it actually speeds up the process of recognizing the electrical cardial findings. So the interpretation, though, is outside of the scope of the EMT. However, if you can place the leads and acquire it, as well as print the tracing of it, when an ALS team gets on site, or you can transmit it to the destination hospital, they can actually tell you and interpret that for you. So if you do send it on to the destination hospital and then contact them, they may tell you to do one thing or the other, or they might just tell you to get ALS or fly the patient. How do you prepare a patient for an ECG? Well, first you want to place the electrodes on the chest. The electrodes need to be secured and have contact with the skin. You're going to remove any clothing and jewelry and remove sweat and dead skin cells, and then remove any hair if the stickers don't stick. Step 1, you're going to place the limb leads. Step 2, you're going to place V1 and V2 leads. Step 3, you're going to place leads V4 and V3. And step 4, you're going to place V5 and V6. So here's a diagram of the placement of the arms and the legs. Some people will put the lower limb leads up higher on the hips, which is, again, it's okay as long as your medical director tells you that it's okay to do it that way, but most times it's easier to get to their ankles if they have pants on. Here you will see the placement of V5 and V6. Care of the patient with acute coronary syndrome. The fundamental principles of care. First, you're going to place the patient in a position of comfort. Then you're going to determine if oxygen should be administered. Respiratory failure, agonal breaths, or apneic should receive high concentration of oxygen via ventilations. Low oxygen saturations receive high concentration oxygen via the mask or a nasal cannula. And then no significant distress and oxygen saturation of at least 94% should not receive oxygen. However, with that being said, if the patient's complaining of difficulty breathing and so forth, I would see no reason not to give them like a nasal cannula at 2 liters per minute, because sometimes it's more of a comfort thing and so forth. So if it calms them down and comforts them, then a nasal cannula at 2 liters per minute is just fine. The fundamental principles of care. So if you're trained, equipped, and authorized to do so, you want to obtain a 12-lead EKG or ECG. So you want to follow your local protocols as to whether to transmit it to the hospital for interpretation or not. So most EMTs are starting to be able to obtain a 12-lead EKG, and then what they are is they are either printed out so that when the ALS crew arrives on scene, they have it ready to go for them so they can read it, or you can transmit it to the hospital that the patient's going to, and then they can read it, and then they can determine if that patient should need ALS service, if BLS service is fine, or if flight might be indicated. So you do want to administer 325 milligrams of aspirin by mouth if allowed, but the indications for not administering it would be the risk for aspiration. So if they can't swallow appropriately, they've already taken a full dose that is within date. Aspirin allergy, if they have an aspirin allergy, you don't want to give that. If they've had a recent GI bleed, you don't want to give it, as well as taking any blood thinners. So if they've not had any of these indications, then go ahead and administer 325 milligrams. So that's either 4 baby aspirin or it's the 2 Bayer aspirin is what it would be. But make sure you check the bottle to be sure that the milligrams are correct. And here's aspirin. It would typically come in a chewable form. So indications for administering nitroglycerin is chest pain, if they're complaining of chest pain. If they have a history of cardiac problems, if the physician has prescribed them nitro, and again, it's to the patient, it's not their spouse or somebody else that's visiting. And then if the patient has nitro at hand. So again, you want to be sure that you are checking that medication for the 4 R's, okay? And remember, nitro can either come in the pill form, and that would be, if you notice here, the nitroglycerin or the nitrostat. So it could be called nitrostat as well. Otherwise, they do have the spray form. I don't think they use that very much anymore, but but it is available. So indications for administering nitro would be a systolic blood pressure that meets the protocol criteria, which most is right around 100 systolic or above. But again, checking your local protocol for sure what your medical director wants you to do is the best option. Next, the patient has not had any Viagra or similar drug for an erectile dysfunction within the last 48 to 72 hours. And then make sure that medical direction authorizes the administration of the medication. Again, either offline or online medical control. So if you have standing protocols that state that you can give a nitro up to 2 times without calling medical direction as long as their systolic blood pressure meets your protocol, they haven't had any Viagra or similar erectile dysfunctions within the last 48 to 72 hours, that may be possible that you don't have to actually physically call. But if you do get to a third time when you have to administer nitro or whatever your protocol says, then that's when you would actually have to pick up the phone and call the medical control to find out what they want you to do. After giving 1 dose of nitro, you want to repeat that dose in 5 minutes if the patient experiences no relief or only has had partial relief. Again, systolic blood pressure remains greater than 90 to 100 systolic or whatever your protocol says. And then medical direction authorizes another dose of medication. And then administering a maximum of 3 doses of nitro. So you want to reassess the vitals and chest pain after each dose. Treat for shock if the blood pressure falls below 90 to 100 systolic, and then transport promptly. However, you have to remember with nitro, it's a little bit of a tricky situation. So if the patient's blood pressure is 190 systolic when you arrive on scene and you give them a nitro and their blood pressure goes down to 110 systolic, do you really want to give another nitro unless you have ALS that can start an IV and have fluids ready to go? I probably wouldn't, but again, checking your local protocols and finding out what your medical director would like you to do in those type of situations, I would say very much do that. It's just you don't want their blood pressure on a second dose. Yes, the 110 systolic is possible to give another dose. However, because it drops so much with that first dose, I'd be very careful giving them a second dose if their blood pressure dropped that low, because now you could bottom out their blood pressure and have a whole nother issue on your hands. In this section, we're going to go over cardiovascular disorders. With cardiovascular disorders, so it can be heart problems that can be caused by a number of disorders that affect the condition and functioning of the blood vessels and the heart. So the majority of the cardiovascular emergencies are caused typically between the direct and indirect changes by the inner walls of the arteries. So these arteries can then be part of the system or that total body. And then the pulmonary is the lungs, remember, and then the coronary is the heart or the circulatory system. So problems with the heart's electrical and mechanical functions also cause cardiovascular emergencies. So when the coronary arteries are narrowed or blocked, that is when blood flow is reduced, therefore reducing the amount of oxygen delivered to the heart. So the conditions that narrow or block the arteries of the heart are commonly called the coronary artery disease, also known as CAD, or some people call it CAD. So the coronary artery disease is a very serious health problem that can result in hundreds of thousands of deaths yearly in the United States. So CAD is often the result of buildup of fatty deposits on the inner and the middle walls of the arteries. That buildup then causes a narrowing of the inner vessel diameter, restricting the flow of blood. Then fats and other particles are combined to form this deposit known as plaque. So as time passes, calcium can be deposited at the site of the plaque, causing that area to then harden. Some factors that put a person at risk of developing CAD, such as hereditary and age, that just can't be changed. However, there are many risk factors that can be modified to reduce the coronary artery disease, and these include hypertension, so which is that high blood pressure, remember, and then obesity, lack of exercise, elevated blood pressure, elevated cholesterol and triglycerides, and then cigarette smoking. So many patients have more than one of these risk factors. So fortunately, the damage caused by the second group of risk factors may be reversed or slowed by changing their behavior. All right, next we're going to move on to angina pectoris, which means it's literally a pain in the chest. So in this condition, coronary artery diseases has narrowed the arteries that supply the heart, and during times of exertion or stress, the heart works harder. So the portion of the myocardium then is deprived of oxygen, which then causes chest discomfort or that angina pectoris, which is the most frequent result. So the discomfort is sometimes called an angina attack. It is important to remember that the chest pain is not the only symptom associated with the ischemia of the angina pectoris. So while the pain or discomfort is common, the ischemia is caused by the narrowed coronary artery that can also cause shortness of breath, nausea, sweating, and syncope. So pain then is typically during the increase of the myocardial oxygen demand, such as that exertion or stress. So then you have the possession of nitroglycerin, which is a good indication that that patient does have a history of angina, because people that don't have a history of angina probably wouldn't have nitro. And then remember that nitro dilates the blood vessels so that the heart has less blood to pump. Assessing and treating angina pectoris. So if the symptoms subside with rest, it is considered angina pectoris. You want to assume that the patient is having a myocardial infarction until proven otherwise. So you want to consider oxygen, administering nitroglycerin and aspirin, as well as obtaining a 12-lead EKG and then transport them immediately. If needed, contact ALS for an intercept. Okay, next we're going to talk about acute myocardial infarction. The narrowing of the coronary arteries sets the stage for several other cardiac conditions. So as plaque accumulates and hardens, it can create a weak area of the vessel and actually make rupture a possibility, which is called an aneurysm. The narrowing then of the vessels also sets the stage for the blood flow to be blocked by an occlusion. As plaque accumulates, the inner diameter of the blood vessel narrows. In addition, the inner lining of that vessel then becomes hard and rough. The rough surface forms the inside of the artery, can facilitate formation of blood clots, which narrow the arteries even more. So then the clot and debris from the plaque forms a thrombus. So a thrombus can reach a size where it's blocked blood flow and actually causes an occlusion. So the clot may also break loose and become what's called an embolism, and it moves to occlude that blood flow somewhere downstream in that smaller artery. So in cases of a partial or complete blockage, that tissue is beyond the point of blockage will actually be starved of oxygen and may die. So if this blockage involves a large area of the heart, such as in a heart attack or the brain, which can cause a stroke, the results could be very quickly fatal. So blocking any coronary artery by a thrombus or an embolism is considered an acute myocardial infarction, or also known as an AMI. So here you will see the cross section of the myocardial infarction. So acute myocardial infarction can cause ischemia, which then leads to the injury of cells and cell death. It also disturbs the electrical function of the heart. Then dysrhythmias is harmful changes to the rate, the rhythm, and the pumping ability. So acute myocardial infarction can cause mechanical problems within the heart, which causes then cardiogenic shock. Then sudden death is when cardiac arrest within 2 hours of the onset of symptoms happens. The treatment of an acute myocardial infarction at the hospital is fibrinolytics or a balloon angioplasty. Treatment upon discharge can be an aspirin every day and possibly a beta blocker. So if you do have patients that are on an aspirin every day or potentially a beta blocker, ask. That's why it's important to ask what medications the patient is on. It'll also help you get the history of that patient's medical history. So if they're on for instance, I'm going to just kind of go off subject a little bit, but if they're on a blood pressure medication and they say that they don't have issues with their blood pressure, then you can ask them a little bit more information about why are they on a blood pressure medication. Because a lot of the times what will happen is the patient will say, oh no, I've been on medication, and since I've been on medication, my blood pressure's been fine. Okay, well that is still considered a medical history that's important to know, because if they were to stop that medication, their blood pressure would then what? It would probably then increase. So then with the assessment and treatment of a myocardial infarction, you have the primary and secondary assessment. Then the pattern of the symptoms are very similar to the ACS or the acute coronary syndrome. So they can have chest discomfort, dyspnea, nausea and vomiting, syncope, and potentially sweating. Most important treatment is transport. You can also do a 12-lead EKG if your service allows you to. Contact ALS to get an ALS crew to intercept with you. Be prepared though for cardiac arrest. And then as long as there's no contraindications, you can give aspirin and nitro as well. Next, we're going to talk about heart failure and acute pulmonary edema. So heart failure, also known as congestive heart failure or CHF. That's when the heart is unable to pump the blood efficiently and the ability to perfuse body tissue is impaired. Exercise-related tasks become difficult, and its limited ability to compensate for challenge. And then it causes fluid buildup. So remember that congestive heart failure occurs when the heart cannot pump blood properly due to the damage or a disorder. So pulmonary edema is a common symptom of CHF. So with the right-sided failure, pressure then builds up in the right atrium and the superior and inferior vena cava. You'll start to notice jugular vein distension, swelling and fluid buildup in the abdomen, and pedal edema happening. With left-sided heart failure, that's when pressure builds up in the left atrium and the pulmonary vein. Fluid then leaks into the alveoli. Gas exchange is impaired. Then you'll get the pulmonary edema, and it can be very life-threatening. So the assessment and treatment of heart failure include during your assessment the history of heart failure. Do they have a history of heart failure? Then medications designed to control fluid levels, pedal edema, swelling in the abdomen or the buttocks, and then JVD, that jugular vein distension. Do they have pedal edema, difficulty breathing? They could have crackles, or they could be coughing up pink frothy sputum. On examination, you want to do your primary assessment, which may require positive pressure ventilation. You want to use that OPQRST and sample history to get some information from the patient. Then you're going to do your detailed assessment of the cardiovascular system, including vital signs. For your treatment, you want to treat all signs and symptoms. Contact ALS for any pulmonary edema. Consider application of a CPAP and administer nitro. Again, as long as it's not contraindicated by your local protocols or if the patient has any contraindications. Next is the aneurysm. So it is a weakened section of the arterial walls that begin to dilate or balloon. So bursting can actually cause a rapid, life-threatening internal bleeding. So remember that an aneurysm occurs when the weak sections in the arterial walls dilate, and occasionally they end up bursting. So a weakened area in the wall of an artery will tend to balloon out, forming a sac-like aneurysm, which again may eventually burst. So as you can see in this picture, it's starting to bubble there. Well, if you take, for instance, a balloon and you put water in it and you keep pushing that balloon up and making like a little bubble and grabbing one section of that balloon and keep ballooning it, eventually it will burst. And that's exactly what will happen within your artery wall, is it will burst. It can only hold so much pressure. All right, let's move on to the chapter review. Patients with acute coronary syndrome, or ACS, can have many different presentations. Some complaints of pressure or pain in the chest with difficulty breathing and a history of heart problems. Others may have just a mild discomfort and that they ignore for several hours or that goes away and returns. Some patients having heart attacks have no chest discomfort at all. Use a thorough secondary assessment to identify the signs and symptoms associated with the pattern of acute coronary syndrome. Because of the many possible presentations and the potentially severe complications of an acute coronary syndrome, it is important to have high index suspicion and to treat patients with these symptoms aggressively. The treatment will not hurt them and may help them. Patients with suspected ACS who are hypoxic or short of breath need oxygen and prompt, safe transportation to definitive care. You may be able to assist patients who have their own nitroglycerin in taking it, thereby relieving any pain or anxiety that they may have. Definitive treatment of an acute myocardial infarction occurs at the hospital. Treat suspected AMI as a time-sensitive disorder. Consider appropriate transportation destinations. Activate system of care and obtain early 12-lead ECG if possible. Aspirin and nitroglycerin are the first-line medications associated with the treatment of acute coronary syndrome. Heart failure is a chronic condition that can have life-threatening acute presentations. You want to recognize the signs and symptoms of acute pulmonary edema and treat aggressively. You want to remember that the heart is a simple pump that moves deoxygenated blood to the lungs and oxygenated blood to the body. Pressure within the cardiovascular system is critical to moving of blood. Remember, acute coronary syndrome is a blanket term that refers to a number of situations in which perfusion of the heart is inadequate. Although there are common symptoms of ACS, EMTs must recognize atypical findings and err on the side of caution. Remember that oxygen, nitroglycerin, and aspirin are key medications indicated to treat ACS. However, the definitive treatment is transportation of the patient to a facility that can open the blocked arteries. Remember that most cardiac conditions are caused by arterial problems. Angina pectoris and acute myocardial infarction are caused by inadequate perfusion of the heart. Questions to consider. What position is best for the patient with difficulty breathing and a blood pressure of 100/70? And then the next question to consider is what position is best for the patient with chest pain and a blood pressure of 180/90? So remember, most patients with difficulty breathing prefer an upright position, although the low blood pressure can sometimes make sitting up difficult. Often the semi-Fowler's position is appropriate. Critical thinking. You have a 62-year-old female has been complaining of severe shortness of breath and chest pain for 15 minutes prior to your arrival. When you arrive, you find the patient conscious with difficulty breathing and oxygen saturation of 88%. What steps should you take in caring for this patient? Remember, you want to perform your primary and secondary assessment, administer oxygen via the nasal cannula, and administer aspirin and nitro if ordered by medical direction. If allowed, you can obtain a 12-lead ECG and transport promptly.